Okay, so we should start because it's 12:10. So it's a great pleasure to introduce Marlise Gonzalez Fernandez. I'm working on it. It's good to introduce Marlise. So folks who may not know, or maybe the residents, so Marlise is an associate professor in the department, and she has been working here in this department for many, many years. Even before she was an associate professor, she was doing research with Tim Dillingham when Tim Dillingham used to be here in this department and working in a lot of the research space. And then after residency in Sinai Hospital, she joined the faculty. And soon after that, she joined the faculty to do research besides clinical work and pursue her PhD in clinical science. So I think it's great to have internal folks to give grand rounds, because what happens is that we tend to deal with internal folks on a regular basis, but we talk about things and so on, but people may not appreciate the type of things that folks do in the academic space. So it's a good idea to have our internal faculty once in a while present to the large group, because not everybody is appraised of what's going on there. So with that, Marlise, you take the podium. Yes.
So it's interesting being here a couple of years that I choose not to do a research talk directly related to the research I do. So that's message number one. This is not a research talk. And why it's not a research talk is because we decided to do something that had broad applicability to the department. So this might have a little bit of a research undercurrent, but this is not a research talk. And why is that? Because I chose to be a researcher as part of my career, but the vast majority of our residents and therapists will not. And I want to make the argument today that even if we're not going to be generating the evidence that's going to drive our field, if we're not going to be directly doing research, we're always going to be having to tap into those resources. We're always going to have to be consumers of that literature to be able to stay in the forefront of our fields. So that's what this talk today is about, is how do we appraise the literature in an evidence-based practice environment and what those competencies are. So I'm not going to have the time today to teach you some of the things that you should know, but hopefully by the end of the lecture you'll know the type of things that you should know so we can later on build upon that. Does that make sense for you folks? So I have to say I have no conflict of interest. All the dollars I make come from Hopkins. So we'll again introduce the topic and talk about the types of questions and how to structure a question in the context of having to answer a clinical problem that you have. And then how do we evaluate the literature? What are the resources that we have? And then again, after getting that evidence, we have to appraise it, interpret it, and apply it. So we'll go through those steps. So what is evidence-based practice? There's multiple definitions out there. One of the oldest ones is the first ones you see here that's telling us that it is an approach to healthcare where you use the best available evidence. But again, it also has to take into account the individual patient. Again, this second definition, which is a little bit contemporaneous to this one, talks about the conscientious, explicit, and judicious use of the current-based evidence, right? And some people might say, well, current best, if it's the best, it would have to be current. But highlighting that evidence changes all the time is really important, and that's why in evidence-based practice, you'll always see this current best term being used. So how can we operationalize that in a way that is meaningful to all of us? So again, the most accepted definition right now by Sackett and colleagues includes these three components. So the integration of the best research evidence with the individual clinical expertise and the patient's unique values and circumstances. So as you can see, the research, the papers, what we're generating every day only affects the top part of it, right? That is the hard evidence we have. And evidence changes all the time, so we have to make sure to stay abreast of what's happening out there. So, for example, yesterday there was a big paper out. So how many people here think that you should take a baby aspirin every day to prevent cardiovascular disease? I'm hearing a lot of no's. You know? How many people thought that that was the case before yesterday? Pretty much everyone. And from yesterday to today, I hardly found anyone that would commit to say that that was the case. So that's how quickly the evidence can change. That's how quickly what's the base of information that we use in how clinical practice changes. But again, that has to be combined with your individual clinical experience and with the unique values that someone has. So will we make a different decision, even in spite of that paper that's talking about aspirin, if the patient that we have in front of us has a very strong history of heart disease and has all sorts of other issues? So again, those decisions have to be colored by the experience and by the patient that we're seeing in front of us. So if we look at it in a graphical way, we're saying evidence-based medicine lays at the intersection of the actual medical evidence we have, at the clinical experience we have, and of the patient values that we need to address. So it's really important to then look at all these factors to really make decisions for our patients on a day-by-day basis. And I would argue that any clinician has to do this on a regular basis, and the question is, how do we find the best evidence and stay up to date on that evidence? So what is not evidence-based medicine? Again, evidence, whether strong or weak, is never sufficient to make clinical decisions. So just to stress the point again that I'll be repeating over and over, evidence-based medicine is not just figuring out what's the best paper or the latest and greatest randomized controlled trial to be able to guide our practice. It's combining all those things to make sure that we are not trying to do cookbook medicine. We're not trying to use a one-size-fits-all approach, which is the main criticism that evidence-based medicine has. And again, it's a totally different concept. So why is this important? Well, 30 to 50% of our patients do not receive care according to current scientific evidence. And then 20% of more of the care is not just needed, but it can be potentially harmful. So again, we all want to do the best for our patients, and we've taken an oath to first do no harm. And as part of that, it behooves us to obtain the best evidence to take care of those patients. So easier said than done. There's a lot of potential barriers. So I'll try to highlight some of them for you. So patient and what the patient wants and can be diametrically opposed to what the best evidence is. What your individual beliefs as a professional can be there. And then there's threats at a healthcare system level, at an organizational level, and a society level. What are acceptable ways of being treated varies from one society to the other. I know people who have volunteered in Africa, for example, and they've brought medications that we all know in this part of the world are effective, but they're oral medications. And in that part of the world, they don't think that the medications work really well unless it's an injectable. So you're working with this construct in their society that says, hey, you have to give me an injection for it to really be medicine, to really work. And again, how do we marry those personal perceptions with the evidence we have is really important. So obviously there's a lot of barriers to implement an evidence-based approach, and I'll try to give you some examples of that. So again, we're in the environment where we practice is really important, that organization context. So there might be financial disincentives to do evidence-based medicine. Perhaps the best treatment for what we are trying to do is not reimbursed appropriately, and those decisions are colored by that. Perhaps we have constraints. We have to see a certain number of patients in a certain period of time. So taking a step back and trying to look at what is the best evidence for this particular patient might not be possible in a real-time environment. Or there's the perception of liability, like you don't want people to come and think that you're doing something wrong by taking a step back, so you don't do it. And again, meeting patient expectations as well is another problem. So as we can see, there's multiple ways where the evidence can start falling behind because of the other demands of clinical practice. So prevailing opinion can be a big barrier to applying evidence-based medicine. So what you're used to do can play a significant role. We've always done it this way, why do we need to change? Or again, you have someone that's quite influential that does not agree that the evidence that's being provided is sufficient to change practice. You can have knowledge that was perfectly fine some time ago. Back to our aspirin example, it was perfectly fine until yesterday to consider aspirin a good thing to prescribe to our patients for prevention of cardiovascular disease, and today we have a little bit of a different opinion, right? And again, pharmaceutical companies, which is something that here at Hopkins we've worked hard to eliminate. The influence that pharmaceutical representative could have on what we prescribe could have been undue, and there's been very clear efforts to remove that from our system. And you have the knowledge and the attitudes of each professional. So, maybe you think the tests are too vague, or you're very confident in your skills, and no one needs to say how I need to do things. Or sometimes we have this compulsion to do something. So you know that this intervention will not be effective, or that the intervention is not necessary, but the patient wants you to do something. So you choose to do something because you have to meet that societal expectation. Or on the other hand, we're overloaded with information. There's papers after papers, how many journals we have, how many opportunities for learning, and there's too much. So it's kind of, you throw your hands in the air, you just can't manage all the evidence that is available to do the work. So what do we do? Well, I think the most important thing is starting to think about evidence-based practice in more simple terms. And when we simplify things into the different parts of it, we tend to do a little bit better. So I would argue that if we take the 5 steps of EBP, which are mostly start with A, we can actually start making a construct that is meaningful in our clinical environments. So the 5 steps of applying evidence-based medicine include asking the correct question, making sure you're putting it in a format that is useful, acquiring the evidence, so where are you going to search, where you're going to find this evidence that you need to make a clinical decision, and then you have to appraise that literature that you found, all that information that is from multiple resources, and interpret that, which is what most people typically think about evidence-based medicine, is that you get the papers and you figure out how good or not they are. But as I said, it's a little bit more than that. And then after you have that evidence and you have interpreted and you have appraised it and you know what's valuable, then you actually apply it to your patient. And hopefully that results later on in an evaluation process where you see how these interventions are working or not, and you move on to continuously improve the practice for whatever we are treating. So if we're going to dissect all these, we really need to ask questions, first of all, that are answerable. We need to make sure that we're focusing on applicable and answerable questions to be able to move the field along. So questions can be classified into two: background questions, so general knowledge about a condition. So you're building up your knowledge. You're a trainee. You are not an expert on fill the blank. I don't know much about, stroke rehab. And you want to learn about that, so you start looking for information. So certain sources are better than others for that type of information. And then you have foreground questions. Foreground questions usually follow the PICO approach, and that is you have a specific patient, population, predicament, problem. You have an intervention or a specific intervention, exposure, test, or agent that you are asking the question about. And you look into what the comparison is to determine what was the best outcome, and then you look at a specific outcome of importance in that particular question. So these things are hard to see unless you actually put questions behind them. So that's what I did next. So an example of a background question would be, how does a stroke cause spasticity? So you can certainly find a lot of sources that will tell you what the pathophysiology is and how to tend with that, and those resources will be different from the sources that one would use for information when looking at a question like, in adults with ischemic stroke and dysphagia. Of course, I had to talk about dysphagia, right? I couldn't do the whole thing without mentioning swallowing. In adults with ischemic stroke and dysphagia, would adding submental neuromuscular, excuse the typo, electrical stimulation to standard swallowing therapy, so that's your comparison group, will result in better 5-year outcomes? And will it be worth the potential additional harmful effects and costs? So a very multiple levels that you can add to ask specific questions. A very applicable question right now in dysphagia, in the dysphagia field, because again, neuromuscular electrical stimulation is the latest and greatest thing for swallowing, and it's unclear what the effects would be. So we're still investigating that. So it would be a great question to keep looking at. So does that make sense? Any questions about the questions? So again, the clinical questions can address multiple areas. So the previous one that I gave you as an example was looking at a treatment, but you can make questions about etiology, questions about diagnosis, questions about treatment, or about prognosis of disease. And the type of evidence that would contribute to you being able to answer those questions will be a little bit different as well. But again, we need to continuously be in the process of acquiring new evidence. And I thought this quote from Dr. Burwell, who was dean at Harvard, was very apropos. He said, this quote, and it says, half of what you're taught as medical students will in 10 years have been shown to be wrong. This was in 1956. And the trouble is, none of your teachers know which half is going to be wrong. So if you're not continuously learning, and you will miss half of the things that need to change in your clinical practice. I would argue that perhaps 10 years in 2018 is long. It'll probably be a little bit shorter because our access to information is much better now than it was in 1956. So the ability to turn around that information and use it is better. So we need to, if we asked a great question, we need to know where to find, how do we acquire the evidence that's necessary? And it's incredible volume. So for most people who are not doing research, this tends to come from what is called PreAppraised evidence. And what is that? If you don't know how to critically appraise research evidence, or if you don't consistently apply criteria to look at the level of evidence, or you don't have the time to look at the evidence itself as the original paper that actually gave you a nugget of information, then perhaps the source to go to first is to a pre-appraised source. And again, what are those pre-appraised sources? Well, people actually did half of the work. You already know if this particular piece is good or not, how much what the rigor of the research conducted was. And at some level, they also put together multiple pieces of multiple papers into one document that can actually help you understand the particular question. So, examples of these pre-appraised evidence locations, for example, a TRIP database, which, how many have heard of TRIP before? Good. So 1 or 2 people. TRIP is a great place to go. It's a database that will research not necessarily primary sources like papers, like PubMed would, but it also searches other areas like clinical guidelines or all sources of pre-appraised evidence. So if anything, I think you all will find this very useful, and it's very intuitive. It's just tripdatabase.com. Yes?
Can you access the Welch portal to TRIP, or is that something external to Welch?
So it is external, but you don't have to pay. I brought you the link so you can see. And all I did was go to TRIP and put stroke rehab. And again, the first thing that it puts there, one of the sources that I mentioned in the previous slides was Dynamed. TRIP actually tells you if Dynamed has something on it. And again, you can see multiple sources. I like, if you look at the right, it tells you the evidence type. So this stroke rehabilitation search pulled out 1,322 systematic reviews, etc. So it really shows you what type of evidence you are looking at, and it'll tell you, again, and it'll go down to show you, you have, in stroke rehab, you have 2,980 control trials. So it gives you a good perspective of what evidence you have, and then you can start narrowing down within those topics. Again, stroke rehab is a huge area, but I wanted to do something that was meaningful for everyone. So again, multiple sources. Most people know about Cochrane and Cochrane reviews. Again, pre-appraised sources. Clinical practice guidelines in the U.S. They are in the National Guideline Clearinghouse. Some of them are in the U.K. are in the Prognosis guidance. Much harder to reach. Again, if you're not practicing in the UK, you would have to pay if you're going to access the guidelines from there. And you got point of care resources. Now, how many of you know of UpToDate? Everyone, all the residents know about UpToDate. So again, a resource that actually pulls in the best evidence, but pre-appraised evidence as well will have some challenges. So what do you guys think is the biggest challenge of pre-appraised evidence? Anyone wants to? Time, right? So someone had to take the evidence that was there, evaluate it, put it together in a document, and put it out. And that lag will potentially be a problem if things change between the moment that all these searches were done and the time that you're actually reading this document. So you have to take into account the time frames when these documents were developed. I saw a hand.
I'm related to your question.
Okay.
But I was just going to ask if you've heard more about the plans to delete guidelines.gov.
To do?
To delete guidelines.gov.
Yeah, so that's been the rumor. I don't know where it's going to end, but yes, they were saying that this was going to be eliminated. We will see. But again, one of the challenges with guidelines.gov was that it was not being updated as often as it should. And again, if you're going to guidelines.gov or any of these websites that are not updated very quickly, very promptly, and you're looking for background information, then perhaps you're okay. Because all those introductory paragraphs that talk about what this disease is and all that are probably still applicable. It's when you're looking for cutting edge information that perhaps those are not your best sources of information. So in the pre-appraised group, there's different levels of evidence, and you want to make sure that you pay attention to what type of evidence you are looking at, and that's where this pyramid is really important. So you can have papers, for example, that now a lot of journals are adding levels of evidence with publication. PM1R, for example, is publishing levels of evidence with all the applicable article, so the purple journal is. So that is, at a certain level, it's pre-appraised. Someone is telling you this evidence is better or not. So you should pay attention to that. That's in your bottom. So you have filtered views, pre-appraised papers, you have synopsis, and as you move along, you expect the strength of that evidence to be better because you have multiple layers of review and multiple people appraising that evidence. So at the top, you have like synthesized summaries. So systems, what are systems? Clinical workflow specific, evidence-based information. For example, you have computerized decision support. So you don't even have to go look for that evidence. You go in Epic right now, and if you try to put a prescription for an opioid, you have certain things that it tells you need to do that we're building in. You know, it says, oh, you're trying to prescribe opioids and it's more than 70 MMEs. Is that what you really want to do? Because the evidence suggests that you stay below this number. So those systems can be built. Again, they take a lot of time, a lot of effort, and again, the updating is the question. And then synthesized summaries for clinical references. Those are resources that really try to put together the resources in the lower 3 layers. So they're really trying to integrate the content meeting clinical reference needs. So again, multiple levels of evidence that you're not doing all the work. But the question is, again, at some point, you need to do some of this work, especially if you've learned a lot of the background information, you have a general idea of the topic, and you need some cutting edge information. You know, patients are bringing you their Google search and says, what about fill the blank treatment? Like, should I do this? Should I not do this? You might need to go back to those sources. So where are your do-it-yourself resources? Well, that's your not pre-appraised evidence. Those are your research papers. And where are they? Well, we all know about Medline. PubMed is kind of one of the best resources we have out there. How many papers, one thinks, are in PubMed at this point? It's close. It's getting close to the billion. Not there yet, but it's getting there. And then you have OBIT, EBSCO, MBase, all again general science-related engines that have papers. But then you also have general search engines, right? Those are our patients' favorites, right? There's Google. But then you have Google Scholar, right? Google Scholar actually tries to look at papers, patents, and summaries. So one has to be careful as well because there's mixed levels of evidence within Google Scholar. But a little bit better than just a Google search on its own or any other engine, Safari or Firefox. So we don't say that we're biased in recommending Google on its own. There's multiple search engines that one can use. But again, it's unfiltered information. We don't know in general search engines what the underlying information is. And we need to make sure that we look at the source. So it's what I tell patients. I'm like, the information is out there in the internet, right? We all find it in the internet. We pull it from the Welch Library. It's still on the internet. The question is, what is your source? And do you know how to appraise the source that you're obtaining your information from? And once you obtain that information, appraise how good it is. And that's the challenge that we as clinicians, as physicians, need to face every day. We need to make sure that we're basing our clinical decisions in the best evidence available. So where does that leave textbooks? So generally best for foreground questions, right? We're trying to learn. So as trainees, for example, textbooks are very useful because you need to start building that base of knowledge upon which you're going to then make clinical decisions. So that's where textbooks are most useful. Some will come out and tell you and be very vocal about textbooks and say they're only useful for recycling. I don't go that far. I think, again, if the test provides references that support each of its key recommendations, that is most likely a better text. And if you check the date of publication of those references and they're fairly current, then you have an idea of how updated that text is. So it's important to look at that and try to make the distinction between what is a textbook written on evidence versus what is a textbook written on personal opinion. And that's what we're really trying to tease out. What is personal opinion versus what is research evidence? Okay, so you guys are all experts now on all these search engines. You know about TRIP, you know about all these other websites. You search, you have all the information that you need, and then you have to do what? You have to determine how good it is. You have to appraise that evidence and interpret it. So you have to determine how valid and clinical important is that evidence you found. That's where it can get tricky. So I cannot, in the time we have today, show you how to do this, but I can give you some guidelines as to point you in the right direction. And in terms, I think clinical importance is perhaps intuitive for us, so I won't talk a lot about that, but let's talk a little bit about validity. And you have to ask some questions that are critical, For it to be valid, what is the population? Who are the patients? Was this paper that is demonstrating XYZ done in a population that is comparable to my patient? What is the intervention, the exposure, or the test that they received? What was the comparison or the control group? Like, how do you know something is better than something else if they were not directly compared? How were the participants selected or allocated? One of the things that is a critical competency is determining whether there is systematic bias on the findings of some sort of research document, and you want to make sure that there's comparisons. Were the clinically important outcomes measured in a blind, objective fashion, and were they measured at an appropriate time from a clinical perspective? So all these questions are core to what we are trying to do when we're trying to gauge the evidence. And when we're looking at systematic reviews, perhaps there's a couple more questions. Was the literature search comprehensive? Was the quality of the individual studies assessed? So again, by no means I'm trying to be comprehensive in the questions we ask, but I'm trying to give you some foundational information. So then what are the competencies? What are really the things that we should try to learn how to understand properly so we can appraise the literature on our own, do the DIY? So again, it's important to understand random error versus systematic error, because that really affects what your results will be, right? So in a randomized controlled trial, you can have random error, and that should have little to no impact on the results of your study, but systematic bias will change your outcomes. So understanding those concepts is really important. What are those major categories of bias, and what's the impact of these on the results? Again, multiple biases can be. That's why, for example, blinding is important, right? Because there's always that inherent bias that whatever you're studying something for a reason, and you always have a hypothesis. You always have an opinion on how the research is going to turn out. And if you don't acknowledge those biases, then you're going to get in trouble. That's why you blind yourself. So you eliminate that bias that you have because you think you know what the outcome will be in a research study. And then understanding uncertainty is really important. And in this, good example is confidence intervals. Like, will you make a different decision if I'm telling you that a certain number of patients receive benefit if I tell you that that uncertainty is very high? And again, what we choose to do and when is important. And again, recognizing differences between association and causation. So another point that is incredibly important. Most studies are only telling us that things are associated, but it's not telling you what happened before. And again, some of the things we need to do, a good example of causation is that, if you're saying that A caused B, logically A had to happen before B, right? So we have people who are against vaccination of children because of its association with autism, right? We've all heard about that. Those papers were actually pulled. They're not considered sound evidence. And why was that? Because there was bias in the investigator thinking that this relationship was real. So he couldn't show that A meaning the vaccination, happened before the child developed autism. And independent people were able to determine that these children had signs of the disease, autism, before they were vaccinated. So understanding those concepts, which might seem in the context of vaccinations to be obvious, might not be as obvious in other contexts. So, but we need to apply the same principles. And again, understanding conflict of interest, funding sources, and again, how that may introduce bias, and the uses and limitations of subgroup analysis. When you set yourself to answer a particular question, you set up a study in a particular way, trying to answer other questions and analyze smaller groups might be challenging, and how that research is interpreted is different, and we need to understand that as well to appropriately appraise the evidence. When we're talking about associations and effect, we need to understand what data is being presented to us. Is it continuous or categorical data? What are the frequency measures that are used, and what do they mean? If you're talking about proportions and ratios and incidence rates, what are those measures, and what is the statistical versus significance versus the importance of those findings? Again, we can find all sorts of statistically different results, but are they meaningful? Are they important for the patients that we serve? A really important point is that lack of evidence of an effect is very different from evidence of no effect. So that's really important when we're appraising new treatments. So we might not know if a new treatment has the effect that we are hoping it does, but that doesn't mean that it doesn't have an effect. There has to be some evidence to say if that treatment has an effect or doesn't, and it's really important for us to consider that when we're appraising evidence. And when we're looking at systematic reviews, there are guidelines to look at to understand if a systematic review was done well. Again, we're going in the realm of pre-appraised evidence. So understanding the differences between systematic reviews, meta-analysis, non-systematic reviews is important. And understanding and interpreting the key elements of a systematic review, again, is crucial. PRISMA over there starts for the preferred reporting items for systematic reviews and meta-analysis. And if you understand the things that they're supposed to report, you'll start understanding a little bit why those things need to be reported. Comparable to basic clinical or bench research, legibility is really important. It's just that you're selecting different. Now you're not selecting subjects, you're selecting studies, and understanding how the characteristics of those studies, the years, the language, the publication status, and trying to see if there was any systematic bias in how those articles were selecting is really important as to how you appraise and interpret the results of that particular systematic review. And again, finding individually how strong is each study will determine the strength of the ultimate recommendation that a systematic review is providing. When we're looking at treatment studies, that's where we start seeing our highest level of evidence, which are randomized controlled trials. So we need to then understand what are the key features of a good randomized controlled trial, and we need to understand the limitations of observational studies when they relate to treatment. Because again, observational studies come from the epidemiology side, which is very near and dear to my heart. But again, when you're talking about a treatment, understanding the factors that can affect if a treatment works or not is really important. And observational studies have clear limitations that one needs to understand. And we also need to understand when we're using observational studies, what are the limitations of adjustment methods and how they're used and how we can understand better. So again, talking about competencies right now. When we're talking about diagnostic accuracy, again, what are the key features of a diagnostic study? Understanding what are the measures of accuracy, understanding the purpose and use of clinical prediction rules. These are the studies where we start talking a lot about sensitivity and specificity, positive predictive value, negative predictive value, understanding how a test represents the truth, like whether a patient has a disease or not is independent from whether your test can detect if a patient has a disease or not. And understanding how the test is constructed is critical to determine if that's the correct test to use in a particular environment and for a particular circumstance. When we're talking about prognosis, how well or not our patients are going to do, again, understanding those studies is really important. Interpreting the results and measures of effect. Kaplan-Meier curves are a good example of what we're doing here. Those are survival curves that start dropping. We see how people do. And again, understanding prediction rules, which have become more and more ubiquitous on the web and in the literature for how patients will do, is important as well. So we'll see multiple times patients will search around, and there's plenty of predictors out there that you can find, calculators on what is your risk of cardiovascular disease, and you plug certain numbers and you get an answer. Well, the answer is only as good as the evidence that is behind constructing those algorithms that determine the risk, and we need to make sure we understand those. Other studies, there's always others. So you have evidence-based versus opinion-based practice guidelines, and making that distinction before we make decisions when using those guidelines is really important. We have harm and etiology studies for rare adverse events of interventions, and those are very different from our randomized controlled trials. Those happen later on after the drugs have been in the market. And we can get really important information from qualitative studies. They inform the decision-making process. We can understand how patients feel. And again, in that triad of evidence-based medicine, the patient's beliefs and their environment is really important. So integrating all these sources of information is critical so we can come to a sound decision. So we found it all. We interpret it all. We have it all together. We certainly need to use that evidence. So what do? We engage those patients in the decision process. We try to recognize their dilemmas, their hopes, their expectations. Again, there's no intervention that works when the patient doesn't use it. Like I typically tell my people with amputations that I'm providing prosthesis, I said the worst outcome is that you didn't tell me what this device needed to do for you, and you put it in the closet. That is the worst outcome. Again, and it could be the same with a pill or an exercise we provide our patient. If we don't understand what they're willing to do and not do, and do shared decision making, all the evidence is going to be moot because people are going to do what they feel comfortable doing. So we need to also recognize professional, ethical, and legal components, and the dimensions of clinical decision making and the role of clinical reasoning. Again, putting all this evidence together is not just looking at papers and seeing what they say. It's incredibly important to help patients understand what is their baseline risk, because their decision might be colored by that information. So again, how likely you are to have one problem or the other is really important so they can decide what is best for them. And again, interpreting the grading of certainty in the evidence and the strength of the recommendation is healthcare is really important. In our field, potentially, we are facing all the questions that patients have about use of marijuana, for example, or all sorts of cannabinoids for pain management. And part of what we need to do is keep looking into this evidence and see how much we have. And, I've had these conversations, say, well, it depends on what you are trying to study, what your problem is. So for pain, there's a certain level of evidence, and we discuss it and say, there's better evidence when looking at cannabinoids for seizures, for example. And we can have those discussions. So I think it helps to parse some of the evidence out for our patients so they understand that, okay, just because it works for seizures, for example, in terms of cannabinoids, it might not work as well for pain or in any other circumstance. And that takes into account the fact that it's becoming kind of the latest and greatest thing that is quote unquote natural, right? Marijuana is pretty natural. It's just a leaf. It's getting dried and smoked. And for people, that is really important. That is a natural product. So we applied all these evidence. We talked with our patients. We figured it out. We figured out what to do. And then we need to always have a loop and evaluate that. Again, recognize what were the potential barriers to using that, understanding how it works, learning from patients that did well and from patients that didn't do well, and bringing that back, and perhaps considering kind of this personal clinical audit in facilitating EBP. It's important to always have a reflective clinical practice, right? What do I mean by that? Thinking about and learning from past experience, and then avoiding the things that did not work, or understanding them better and seeing how they can be applied differently. It's really important. And again, the ones that work well inform our practice as much. We tend to concentrate on the things that don't go very well when we're taking care of patients, but we should also focus on the things that work well and have all those things be influential in our clinical practice. So I think you all are experts, can go from 1 to 5 and ask the right questions, get the right evidence, appraise it, apply it, and evaluate it. So I will leave you at that. I'm going to try to be mindful with the time, so thank you. Questions? Well, that's easy. Thank you.
Okay, I have a 5 to 10 minute presentation that I hope everyone will stick around for. Thank you, Dr. Gonzalez,
Yes.
for that great talk about.
You'll need to
Oh, do I need
switch.
to bring my laptop?
No, there's one here. You
Oh, there's
just need
one
to
here.
hold it.
Okay. I'm Stephanie. I'm one of the chief residents, and Alexis, my partner in crime, is not here today, unfortunately. But we're teaming up with Dr. Tracy Friedlander and Michael Friedman to hopefully make Grand Rounds the greatest experience possible, basically. It's the opportunity once a month for our whole department to get together where physicians, nurses, neuropsychologists, physical therapists, occupational therapists, and speech therapists. So we have this great opportunity to kind of pool together and kind of break down the barriers between the silos of our specialties. So, we're planning like the full year of Grand Round speakers. We're asking all of our speakers to speak to every one of those disciplines and make it relevant for all of us. So Dr. Gonzalez's talk was perfect in that we all have to know how to find good evidence, appraise it, and apply it to our clinical practice. Thank you, Jack. I'm just gonna pop my talk into this and hopefully pull this up here. I'm going to be presenting on the naloxone research that's been going on Myers 7 and has now spread to Bayview. Let me see. Documents. Movable disk. There we go. And so I'm hoping, I was supposed to open for Dr. Gonzalez, but for timing-wise, I'm closing. I'm hoping that other trainees from our fellowship and training programs like therapy residency and neuropsychology fellowship, that we can all kind of share the work that we're doing, the research that we're doing with the whole rest of the department. So this is my talk on developing and implementing an opioid risk reduction program in our Myers 7 unit. Basically, we all know the opioid crisis rages on, and the Surgeon General has made a statement about it. We know people are dying of opioid overdose, or at least experiencing adverse drug events because of opioids, and it's widespread. And this really stemmed from like the 80s and 90s, like where the belief was, oh, opioids are great, just give them out, they're great for pain. Obviously, we know better now. I don't know why this keeps doing this, but so we got to ask ourselves, which of our patients are at risk for opioid-related adverse drug events? How many non-opioid pain management strategies do I discuss with and offer to my patients? And are my colleagues and fellow care team members just as prepared for such discussions as I am? So a lot of the literature we looked at in writing the manuscript for this project, a lot of the population were people who are in prison, or former heroin drug addicts who go to methadone clinics, people who've had overdoses in the past. Are they the ones at highest risk for opioid overdose? Maybe. But on Meyer 7, the little old lady who goes home with her little old husband who doesn't know their dose of oxycodone and is giving accidentally double the dose, they're just as much at risk, right? So our project kind of went in with assessing risk factors for patients, and then we realized everyone on opioids is at risk for opioid adverse drug event. Anyone around them who has access to their home, who has access to their pills that aren't used, they're at risk for an adverse drug event. Non-opioid pain management strategies were key to the success of this project because we had to educate providers and patients about what else can I do to manage my pain. I don't just want to get rid of the pain down to zero. I want to find a long-term strategy to deal with this pain and maybe live with it for the rest of my life. And make sure my colleagues and my care team and maybe my patients and family members are prepared for those types of discussions without feeling discriminated against, without feeling like they're being accused of being drug addicts, because that's certainly not the case for most of our patients. So this is kind of what I just talked about. The wide availability, improper storage and disposal, and lack of education and counseling puts all of our patients at risk. So, you know, I did a surgical internship year. We would just send everyone who had surgery home with like 2 weeks of oxycodone 5. Like, that's just what we did. We didn't counsel them on, you know, what is the plan for pain management and what are the risks. No study to date has evaluated an opioid risk reduction program in the setting of the inpatient acute rehab. So like I said, all the settings were like community-based programs or like people who just got out of prison. And those are all good starts in the literature. And a lot of these programs were not just opioid risk reduction, they were naloxone, take-home naloxone. And we all know that naloxone is the reversal agent for opioid overdose, but it's transient. So not only do you give the naloxone, you have to know how to recognize signs of overdose, you have to know how to administer it, it's IM, it's intranasal, and you have to know how to call 911 and get an ambulance because they're probably going to pass back out again after 30 minutes. So the goal of our study was to implement this kind of program in an inpatient rehab unit and reduce our patients' risk of opioid-related adverse drug effects. So this was our setting, Meyer 7, it's 18 beds. We tracked data from July 2015 through November 2016, and we kind of broke that up into sort of a baseline, what are our opioid prescribing trends just in general, and then after our intervention, how has that changed our opioid prescribing trends? We looked at data for 788 patients, which is a good number, I'd say. And these are the breakdown dates. And our outcomes we basically tracked were if a patient was eligible, so if they were on opioids, cognitively intact, going home and had a family member that could undergo training with them, were they discharged with naloxone? And after the fact, if they started on opioids, were they actually discharged on opioids? Because some people get off opioids entirely while they're at rehab. So that's our eligibility criteria at the top. What we did was we had patients and family members engaged in discussions about pain management and opioid risk reduction at every level of care. So with the physician team, with nursing team, with pharmacy, and with therapy, because all of our patients are going to experience more pain when they're in the gym. That's just kind of how we have to push them and how they get through their rehab period. So everyone who met the criteria for naloxone was offered a prescription for naloxone and underwent this kind of education training. We use lots of different modalities of training. So there's a video about take-home naloxone and opioid risk at home. We gave handouts, we gave in-person demonstration with naloxone kits, and different websites, different resources. And this actually generated a better collaboration with pharmacy because we realized that naloxone was very difficult to get a hold of. It's still pretty expensive, but we didn't even widely have the intranasal route available. And so now that's much more streamlined because of this research. So that's pretty cool. This is a workflow diagram. You don't have to read too much into this, but basically it describes when a patient got admitted, we'd screen. Are they on opioids? Are they cognitively intact? Do they have family members? We talk about it in the team, like the daily team rounds. And then if they were determined to be eligible for naloxone, they went through the teaching of different modalities. We had some TigerNet videos, we had a tablet education module, and we had paper handouts. And then the patient would agree or not agree to receive the naloxone prescription. It's not benign, it's not cheap. But usually we took patients to say, most people said, yes, I'll take naloxone. And some of the reasons people declined were they still thought they weren't at risk and they didn't need it, and that was fine. At least they got the education. And so that's kind of a different study. Oh, this is an example of one of the handouts we used that was made early on in the project. This is a nice fishbone diagram that Leanne Sprankle helped me make. Actually, she just made it herself, and then I helped her edit it. But it basically, we targeted different barriers to being discharged with naloxone. So there's a bunch of process issues, people issues. So one example of a people issues, there's patients who feared the method of naloxone administration. So some people didn't like the IM, they didn't like the needle. So that's why we transitioned to, just offering everyone intranasal. And now that's becoming more and more common. And initially there was also problems with covering the cost of naloxone, so social work helped us get more vouchers for supporting that. These are our patient characteristics. Sorry, I don't know why this keeps happening. Basically, we broke it down to the pre-QI period, which is our baseline data. That's the left column here. And I'm just trying to compare all three groups in that during the pre-QI period, the early QI period, as in right after we initiated this teaching and this screening of patients, and then during the late QI when the ball was really rolling and we were streamlined, our patient characteristics did not differ significantly. You had the same kind of range of ages, you had the same smattering of diagnoses, same breakdown of races, and you'll also see that the same, on average, the same number of patients prescribed on opioids who came to ACIR on opioids did not change significantly. And another cool thing we looked at is we looked at admission and discharge pain scores, and this just happens during the initial nursing screening, what's your pain score when they first arrive and then when they leave. And pain scores didn't change significantly either. We eliminated the 0 pain scores, so we get some higher numbers. But it's nice that even though we implemented this, aggressive opioid education, people weren't in more pain because they were on less opioids, which is pretty cool. Here's a general schematic of a couple of different pieces of information. So if you look at the thick broken up gray line here, this is the number of patients admitted on opioids each month. And this is during the pre-QI, early, and late period. So this is the whole span of our data. The number of patients admitted on opioids pretty much didn't change. It's about 30 or so patients on average per month. And then the thick black line, number of patients discharged on opioids each month. So you can see the downtrend of once we started the early QI period, this started to trend down. And then percentage of patients discharged on opioids, so this is percentage, that is also reflecting a greater downtrend of the number of people coming in on opioids and then them subsequently leaving without opioids improved. Here's some more schematic breakdown. So this represents the, let's see, patients admitted on opioids and patients discharged on opioids. And so the baseline data shows about the same number of people were admitted and discharged on opioids. So that doesn't significantly change. But once we implemented the QI project, this was the number of people admitted on opioids, and then this is the number of people discharged on opioids. So there's this probably significant drop. All the data of analysis is not finished yet, but clearly this is a notable change. And then obviously naloxone prescribing went up once we initiated this. There was no policy before this project started on discharging anyone with naloxone. So probably the people who went home on naloxone before this QI project started were those who were really at risk, they had a history of drug abuse, and I think we don't have a lot of data on who got naloxone before this QI project started, because I don't think it was a lot of people. And here is obviously more people leaving with naloxone in the late QI period versus the pre-QI period. Okay, so what do we take away from this? I want to be speaking to not just the physicians, but also our nurse practitioners, our therapists, and our psychologists. Because of this intervention, more patients than anticipated have been completely weaned off of opioids, or Schedule II opioids. So tramadol is a Schedule IV opioid. There's less risk of habit-forming behavior or overdose, but still. This required a change in the culture of healthcare delivery. So the whole team on Meyer 7 had to change the way we practice, had to change the kinds of discussions we had with patients and families, and the kinds of discussions we had about barriers to discharge during team meeting. You can't just tell providers to educate their patients about the risks of opioids, and you can't just tell patients they need to go home with naloxone. It was much more difficult than that. And it required like multiple conversations, reinforcements. We have a rotating staff, and any other hospital with an inpatient unit will require that kind of effort too. Patients are often unaware of the potential serious long-term side effects and risks of opioids, and education can easily be incorporated into conversations about pain. So every time you talk about a patient's pain, that's an opportunity to say like, hey, opioids are indicated right now, you're still healing, you just had surgery, whatever it may be, but the expectation is that you won't need these long-term, these are not good for you long-term, let's bring in all these other modalities and get the patient to motivate themselves to find other strategies. Educating providers is as important as educating patients. And again, multiple conversations about pain reinforce learned knowledge, and managing expectations about pain control over time is key. So that is my spiel. That was a very quick overview of this really big project that took a lot of effort from a lot of our disciplines. And it's still ongoing now, and we've kind of started it at Bayview. And the data is not completely analyzed yet. We're still working on the manuscript, but I'm very proud of this project and everyone who helped me with it. Thank you. Any questions? Dr. Wagner.
This is a great project. I know a lot of residents, a lot of attendings, and of course the staff on Meyer 7 have been working on this now for 3 years. And this is a great, in my mind, a really stellar QI project that makes a real difference. And so I think we'll be really impressed with this. The data is pretty clear, and I like the fact you don't need statistics to read it, because you need statistics if I don't have anything. So what I would encourage you, though, is to, with all due haste, get a paper out as soon as possible.
We're working on it. Yeah.
People are desperate for information like this, and I think the fishbone diagram of the contributing causes and the multimodal educational approach you took, is something that's fairly feasible to do, and people are looking for stuff, looking for data on this. And but I can tell you that if you wait on this paper another year, there'll be 40 out already.
We're hoping to submit the manuscript when, Dr. Hoyer? The next month?
I'm encouraged by this, and I think we shouldn't let the perfect stand in the way of good to getting this paper out, because I think it's a way of showing something that can be done in a practical way, because you didn't have funding to do this intervention. You were able to do the intervention and get a significant result without funding.
Yeah.
And that means a lot to the translation, right? That means a lot to the translation.
Right, it's talks of feasibility. So I'm going to maybe put people on the spot a little bit. I just asked Megan, and she was happy to offer that. We're actually very close to a mature version of the manuscript. But I think, again, you mentioned this has been really kind of an interdisciplinary kind of collaborative pact, but a lot of the people that were involved maybe don't have a lot of research background, and I would really hope that some of you may volunteer to review the article and provide some feedback and input, some wordsmithing, grammar. I think that would be really helpful, so that we can really try to get this in as high impact journal as possible. So I don't know if I raise a hand, any of the faculty here, because I think we'll be pretty close to being able to send it out. So I know Megan said that she would do that. Is your opinion?
I'll take a look.
You would take a look, Steve? Anybody else?
Thank you.
I think it's just a very nice, and you're not going to get the New England Journal on this.
Maybe archives.
Nowadays,
I think
as
your archives.
Maurice just showed us, you don't need to be in the New England Journal for people to find the paper.
Right.
I mean, if the paper has the right keywords and people are looking, for inpatient opioid management, it's going to show up even if it's as long as it's in a reasonable archive journal.
Was there another question?
It's question, comment.
Sure.
I wholeheartedly agree with Steve. This is so timely, and get it out right away. I think it's important. It's going to have great impact. And just either question, comment. It seems like you guys can do so much in terms of what kind of data longitudinal quality of life. I mean, there's just so many reduced risk over time for
Absolutely.
chronic pain, opioid addiction. I mean, there's just so many rich questions. I guess if I was thinking of asking the specialist if you guys have thought about what next steps or what other data collection options are. But
Yeah, like right now, our next step is to focus on rolling this out of Bayview so we can widen our pool. But another thought was longitudinal follow-up. Like we have our list of 788 patients. It would take a lot of effort, but phone calls to each of these patients to see have they had to use naloxone, have they had an adverse drug event, are they still taking opioids? All those things are something we'd want to explore in the
maybe
future.
some sort of questionnaire in terms of
Pain control?
well, yeah, pain
Quality of
control,
life.
Did these folks, are they at higher or lower risk now of falling into that chronic pain
Mhm.
category? Is there actually a positive impact on quality of life because they're more in control? I don't know. I mean, there's just we have to collaborate, but
yeah.
to me, there's just so many rich questions.
Those are great ideas. Yes. Julie?
Can I just
Oh,
say something
sure.
real quick to that? Megan, I think you bring up a good point. I mean, in some ways, I think what we're demonstrating in this project, and I think to Steve's point, is almost a feasibility study. I mean, without any funding, you've been able to have really amazing effects. Now you raise the questions of, what are really the outcomes of this, longitudinally when patients go into the community, and I think that's something that we would require funding to accomplish, but I think if there's interest in the department for, collaborating on that type of effort, I think it's a great idea.
Did Julie have a comment?
I just, since you're talking publication,
Yeah.
rehab unit, Meyer 7 wasn't open at that period of time, so just make sure.
Oh, yeah, it was called Halstead. Okay.
Halstead 3, and during that time period, I think the number of beds changed and things like that. You just hate to have something like that somebody would catch and just.
Okay, yeah, that's
or
important.
Something like that.
We kind of refer to it as an 18-bed inpatient rehab unit. I don't think we'd say Meyer 7 necessarily, but we'll double check that.
Make sure that those details are correct.
And did Margaret have a comment?
We were 18. We were 18 then.
I
Yeah.
remember your signs.
No, we were 18 Meyer 7.
Yeah.
We were 18 beds.
Probably just, yeah.
Check your dates of beds, that's all I'm saying.
Okay. Thanks, Julie. Margaret, oh, sorry. Hold on, yeah, sorry, Margaret, really quickly.
So I just thought it was really cool that this was a multi-year project that was done by residents. And so there was probably transitions as people graduated and moved on. And I think that's really rare to see in QI projects. Normally we aim for something that's like within an academic year. Can you comment a little bit about how you organize that?
Okay, yeah, definitely. So Saul Rojani, he was chief 2 years ago when I was a PGY2. He noticed one of his little old lady patients bounce back because her husband was accidentally giving her twice the amount. And he realized, this is not the population that you would think of overdosing. You always try to profile people who have a history of addiction or whatever. So that's kind of what spurred all of this. And in collaboration with nursing management, PT management, social work, pharmacy, it just kind of came together. So I joined once this was already kind of in the data collection phase and the early QI phase. But you're right, it takes a collaboration. So that's what, even though there's no funding, it was all energy and time for people to kind of, in addition to their clinical duties, take this on. But it's because everyone cares about this, everyone recognizes the importance of this.
Perhaps on that note, if they're not going to be authors on this, then there is acknowledgement of these folks.
Oh, absolutely, yeah, throughout the article. Yeah, Megan.
So, you guys probably are in an insular group. I mean, you guys know that this is like a special group of people who realized early on that taking the time to talk to your patients about this is important. There are physicians in other parts of the distribution, in other parts of the care continuum who don't regard this as important and think it's not a good use of time.
Mm-hmm.
And so I think that that's one of the huge messages of this paper is that investing your time and your
Mhm.
energy and having these conversations early and often is going to pay off for the patients and for the healthcare system
Absolutely.
in the long run. Because the Narcan part is important, but so small. It's the
Yes, absolutely.
Rates down. So I hope you guys are patting yourself on the back for creating that special group and for sort of leading the way for other.
Definitely. And we're going to emphasize that in the manuscript. We got invited to speak as a podium presentation for APM&R, so we will definitely focus on that. Any last comments before I wrap this up? That's right. That's right.
Yeah, this project has been presented at I think it's been a nice
AAPM in April.
For also our residents to get some, to put, nice things on their CV, but also really an opportunity to spread the word. I mean, you guys mentioned a couple, but it's been presented.
So many times, yeah.
6
But it's growing and developing and sharing. So just to wrap up, Grand Rounds, we want this to be sort of a way to showcase even learners and trainees in our department and not just invite speakers from outside. So if you know therapy residents, neuropsychology fellows, or like even our own medical residents who want to do like a 5 to 10 minute spiel about their research or topic of interest, definitely reach out to me or Michael Friedman, Tracy Friedlander, Alexis Koslick, anyone else who wants to be on the Grand Rounds Committee. We could definitely use your help and your ideas. Thank you. Yay.